Great. Thank you, everyone, for attending today. And for those who will be watching this on YouTube. And thank you, Nicole, for that kind introduction. We're going to focus today on kind of a very brief overview of what we think might be next within the realm of deep brain stimulation, with a strong emphasis on in Parkinson's disease. This is a list of my disclosures as well as of the Division of Movement Disorders at the University of Colorado. We do have quite a bit of industry support for a lot of our efforts. I don't think any of these are going to be that relevant to today's talk, however. So this is the final lecture of a course series that we have had. We started this series back in January, and we started really broad in discussing about deep brain stimulation, then went into what a candidate is, and then talked about some of what the options are, and then dived into local field potentials. And now we're kind of going to summarize in the next several slides some of the highlight points of these previous presentations, as well as kind of talk about what we think might be next in the near future. So we started off with Dr. Awesome talking about what deep brain stimulation actually is. And we were introduced to this concept of the term advanced Parkinson's disease, knowing that there is no clear definition to advanced, but we tend to think about it in the context of the individual developing motor complications. That being that they have on-off fluctuations, meaning when the medication is working to when they feel that the medication is not working, as well as potentially developing dyskinesias. When we start to see these type of findings in an individual, that's when we start to ponder, should we be thinking about alternatives to medication? And we use these alternatives, the oral medications, as, quote, advanced treatments. And this can include, as Dr. Awesome had discussed, some of the infusion therapies, such as intestinal or subcutaneous continuous infusion therapies, as well as high-intensity focused ultrasound, also termed MRI-guided focused ultrasound, gene therapies potentially, as well as a high emphasis that we talked about with regards to deep brain stimulation. We then went into what is deep brain stimulation, meaning an electrode that is placed deep into certain areas of the brain. And in Parkinson's disease, those two regions include the subthalamic nucleus, as well as the globus pallidus interna that is shown here. We also talked briefly about how you can have success with any of these treatments, again, with the emphasis in deep brain stimulation. That includes making sure you have appropriate patient selection, you have optimal placement of that electrode directly into the target, and then obviously we have very good programming thereafter. And these three components are essential to ensuring that we have good success with our treatment. We then jumped in with Dr. Baumgartner discussing about what is potential candidate criteria for considering some of these advanced therapy options. He led us into the discussion about what does it mean when you have early disease, moderate disease, and then, quote, advanced disease, and talked about this window when you take medication and you start having to develop side effects and or dyskinesias and or motor complications or fluctuations start to get more narrow as the disease progresses, and an individual has to take more frequent medication and or more medication or a series of different types of medications to try to augment and maintain as good of a quality of life. He then talked about some of the inclusion as well as exclusion criteria. Again, the diagnosis needs to be confirmed, that being a Parkinson's disease. He talked about the levodopa response, levodopa being an oral medication that becomes dopamine within the brain. And we tend to like to see a 30% improvement of the motor symptoms. However, that does not include tremor, for example, that might not respond to medication. He talked also about if they failed medication, that might be a potential caveat for some indications. Again, the individual must have realistic expectations. He talked about symptoms that tend to improve, as well as symptoms that tend not to improve with deep brain stimulation. And then he also went over some of the exclusion criteria: mood, cognition, dementia, if they have got a lot of surgical comorbidities, and if they have severe brain atrophy, this might be a concern. Next, we had Dr. Ojman. He talked about what are the basic options, and he did much deeper dive into what does the surgery entail. He did discuss with us as well, what does an evaluation process take? And you can see here, there's a number of steps that are involved with an initial evaluation for candidacy that really involves a multidisciplinary team to ensure that we are selecting ideal candidates for this elective surgery. He also discussed how we target, how he places one of these electrodes into these small regions within the brain. And he introduced us into this concept of sweet spots and sour spots, that being ideal locations where we want to put the electrode, and then other regions where we would want to avoid. He kind of talked to us a little bit about this network, that we have this disease network, and we want to really make sure that we place these electrodes right into that network so that we can provide stimulation and disrupt that network and maintaining or bringing back forward an individual's normal activities. He talked about this network and how we can now see this within the operating room to ensure that we're placing the maximal number of contacts to greatly disrupt this network. And that's kind of shown here, that you can see this contacts 11, 10, and 12 are really in this red area, or this hot spot, if you will, of activity that is not normal activity. And that's where we really want to disrupt this activity. And this is within the subthalamic nucleus. And finally, more recently, we had Dr. Thompson talk to us about local field potentials, which is a really key component and a very hot topic today and relevant to my talk today. And local field potentials are really the summation of neuronal activity around an electrode. So you can think about it as you have a single unit action potential, for example, and you have a number of these, 1 millimeter or so around the electrode, and you summate. So you summarize all these neuronal activities around that electrode, and that's what you end up getting, these local field potentials. And he talked to us about some of these abnormal firing patterns that we can see within this summation of neuronal activity. And he broke this into these basically 5 main firing frequencies that we can think about, that meaning how fast the neurons fire or discharge. Delta being that they discharge very slowly, and gamma being that they fire very quickly. So they're triggering off a high number of times. And he brought into the concept that this beta activity, that meaning that when cells fire between 13 to 30 hertz, especially when they're firing around this 13 to 20 hertz, is really not a normal brain activity, and something that we particularly see in individuals with Parkinson's disease, especially within the subthalamic nucleus. He talked to us a little bit about how we're using this biomarker of low beta, being again the firing frequency of a neuronal activity of 13 to 20 hertz, and how we use this to really make sure that we place an electrode right into that network that is disrupted, so that we can return the individual back to more normal motor activity. He also then brought in the concepts about how we might think about using these local field potentials in our programming. And he also had talked to us briefly about how we might use this in the operating room, and then how this correlates to then this stimulation field, or what we term the volume of tissue or volume of neuronal activation, where we want to really stimulate particular regions of the brain. So what's next? So where are we? Well, a lot of what's next is actually already here. And I think it's helpful to kind of talk about what's here, because then we can talk about what might be in the near future. So if we talk about, for example, intraoperative, and you've heard a lot about this kind of mentioned, we're already doing this right now in the field. So for an example, if our target, meaning the bottom part of where we want to place an electrode, let's say is at 0 millimeters, we can record all along that entire trajectory to see when do we identify this abnormal pattern of discharges of the neuron. And you can see here, we find that this abnormal discharge of this neuron occurs anywhere from 4 millimeters all the way to, let's say, about 1 millimeter above our planned endpoint of where we're going to place that electrode. So we have a span here of 1 millimeter to 4 millimeters of 3 millimeters of space. This allows us to ensure that we're placing one of those contacts within this region of the brain. However, it doesn't necessarily tell us which one of these contacts, and as you can see here, this electrode, for reference, has 3 horizontal contacts, or we can say directional contacts. And it doesn't tell us which one of these contacts one might want to try to utilize. We have the ability now to record directly from the DBS electrode. So once that electrode is implanted, and ensure that we do see this abnormal signal that corresponds with our microelectrode recordings. So that means when we tend to do deep brain stimulation here, we do microelectrode recordings, meaning we first place small electrodes to record along the track to ensure that we're in the right location. Subsequently, we remove those electrodes and place the deep brain stimulation electrode. But now we can also record directly from that deep brain stimulation electrode. And that's might be of value because some electrodes, by the way, once they're implanted, don't have the ability to record. And so we can inform the individual doing the programming, as an example, that for this point on the left electrode, contact 2B had the greatest amount of beta. Consequently, the individual might want to try to program along the level of 2A, 2B, and 2C. And granted, there can be some rotation of the electrode, but 2B might be one to want to look at. In the bottom example, what we see is that contact 3 and contact 2B have the greatest amount of activity, or of this abnormal signal. Well, in this context, what we might want to do is pull back on the electrode. So we might say to our neurosurgeon, for example, or the neurosurgeon will decide that she or he wants to pull the electrode back, withdraw it by 1 millimeter or so. That would allow more of the directional contacts to be within this hotspot. And I'll go back one slide to demonstrate. So for example, if we get all this activity really on contact 4, that's not a directional contact. Hence, what we might want to do is pull this electrode back to allow more of the contacts of 3A, 3B, 3C, or 2A, 2B, 2C to really be within this region of the hotspot. The utility of this we're currently looking at as far as how does this correspond with what we obtain in the operating room, and can we bring that forward, obviously, directly into the clinic to aid in programming and therefore maximize the likely benefit of our patients. An important point here is that these electrodes are now becoming increasingly more complex. as I've already mentioned to you, the middle level contacts are directional, meaning that there's 3 of these per level, plus the one on the top and the one on the bottom here. And we can stimulate from any one of these contacts, either by joining all 3 of these together in the center to make something we call an omni or ring stimulation, or you can stimulate directly from one of these segmental contacts, and we term that being directional stimulation. However, as I'm alluding to, we can now, with certain contacts, program a multitude of different stimulation parameters all along the electrode, meaning you can add 50% stimulation, for example, onto this contact, 20% onto this contact, maybe another 30% onto this contact, and the remainder 20, for example, onto this contact, and really create these complex shapes that are directly, hopefully associated with an improvement, individualized, personalized to that person. These become increasingly more challenging to determine how do you know what percentage of stimulation to add onto each one of these contacts. And I think this is important because what we're thinking about is these complex shapes really, and this is a representing example of tractography, really targeting the networks that we want to disrupt, in this example, a hyperdirect pathway being in orange, and wanting to avoid associative regions and limbic regions, for example, the subthalamic nucleus, that we really want to avoid. So we can create these complex shapes to maximize disrupting the pathological pathways. And there is some notable evidence to support that this is something that we really should be thinking about in our programming. We already know that directional leads are far superior in benefit in some situations compared with ring stimulation. And this is the progress study, which was one of the largest studies, or the largest studies using directional contacts. They had 235 patients. They did an interim analysis, by the way, at 66 patients at 3 months. And what they found was that 89% of patients had a wider therapeutic window, which was increased by 35% with directional contacts. And therapeutic window means when the individual first notices benefit. So let's say, hey, we got benefit at 1 milliamp, to when they can't tolerate any higher amounts of stimulation, when they get what we call stimulation-induced adverse effects. And let's say that would be at 4 milliamps. Hence, your window of 1 milliamp minus 4 milliamps is a 3 milliamp window. And we can find that with the directional contact, that window is much greater, meaning either they have greater benefit at lower stimulation, and or more commonly, you can increase that stimulation to much greater milliamps before they get adverse effects. We also found that they had greater clinical benefit was achieved even with giving less energy of 30%. So we know that directional contacts might be of greater utility in some situations compared with omni or ring stimulation. Furthermore, expanding upon that, we know that fractionation, again, this means when we're adding certain percentages of stimulation all along the electrode, also might be of greater benefit. We did a study of a total of 7 patients in this example here, in which we tested this theory. And we actually did determine that there was no further worsening with what we termed fixed parameter stimulation compared with a non-fixed parameter or monopolar review, which we tend to use here. And it was able to be performed within a fraction amount of time, and a number of patients had greater benefit. With that being said, we also know from the larger fractionated studies, the Advantage and Intrepid trials, that approximately 60% or greater of patients are actually preferred to be programmed within fractionation compared with a directional or omni or ring type of mode. So this gives us clinical evidence that, in fact, these more complex shapes might be of greater utility. But this gets really challenging now. And the reason is because how do we know what personalized shape to program for that patient? Especially now that we're having increasingly more complex electrodes. As an example, this is an electrode that is now readily available. And this electrode has 3 directional contacts uh, along 4 of the levels, with the last 4 being non. So this has 8 different contacts. If you think about this, you've got a total of 4 contacts up here, and you've got a total of 3, 6, 9, 12 contacts. This is 16 contacts to be able to be programmed. And if you're thinking about an individualized shape and you can add certain percentage of stimulation along any one of these, this becomes even more complicated. This electrode also has 16 contacts. It's just that the top contact here is segmented into thirds. I already mentioned what we can do is we make sure that we place one of these contacts, if not multiple contacts, certainly within this region of high beta activity. And in the future, we'll probably be looking at other biomarkers. But in this example, within this low beta range, we want to make sure that we place one of these contacts. And the reason why we're so interested in low beta is in part because we know that this corresponds within, for example, the subthalamic nucleus into that sensory motor target of this region. We don't want to place an electrode within the associated or limbic regions of the subthalamic nucleus, as this will not result in the greater benefit for the patient. We really want to target that sensory motor region, and we see this low beta within that region. In addition, this low beta corresponds with movement. So if the individual moves, low beta goes down. In addition, if you take medication, the low beta also reduces. And if you're being stimulated in the correct target, the low beta also reduces. And this all corresponds with an improvement of the patient's symptoms, and that being in particular slowness of movement, which we call bradykinesia, as well as with rigidity. Now, what previously we had over the past couple of years was what we termed bipolar sensing. So now we can actually record directly off that deep brain stimulation electrode months, years after the electrode has been placed. So you don't need to have circuits outside to a computer and that person tied in externalized wires. This is all internalized. We can record this directly off of the battery now. This is incredibly potentially very powerful. And what we had before was what we call bipolar stimulation, or sensing, meaning you had to take the difference between the different contacts, including along your segmented contacts, to try to infer what might be the optimal contact to stimulate. And as an example here, you can see this pink outline here might be the greater contact, but you don't know if this corresponds, for example, to 3B, or is this, for example, 2A. Now what we have the ability is we can now do over the past month or so within the United States, monopolar sensing. So in this context, you can see, for just example, if you look at the segments, a much clearer, higher amount of stimulation directly corresponding, as an example, to 3A. And you can say, yep, 3A has the highest amount of beta signal. Hence, 3A along my contact is where I might want to concentrate my stimulation. We performed one of the pivotal trials looking at this type of technology. We had a total of 10 patients, total of 20 hemispheres consequently, and we performed this at initial programming. So we compared monopolar sensing, where all we did was record directly off of that contact, and that takes about 5 minutes. You find out which contact has the greatest beta, and that should be consequently then the contact that we should be programming. We compared that with our traditional monopolar review, and again, that took about an average of 2 hours compared with a matter of 5 minutes, and evaluate what were our outcomes. This is a list of the patients and their demographics. You can see they were fairly similar. Their age was around 60. Disease duration was all the way out to 9 years. They had quite a bit of medication they were taking. They've had quite a bit of good response to medication. That's a key factor. And then this is between the two visits that we had to do because we did one side of the brain at one visit and then the other side of the brain at the other visit. What we were able to find was that stimulation by performing this with our monopolar review indeed took about 2 hours, and in relation compared with monopolar sensing, which really just took on the order of minutes. We didn't find any significant difference amongst any of the clinical outcomes when you only program one single contact compared with that of what we obtained with a monopolar review. And in over about 75% of the contacts, the monopolar review actually selected the same contact that was predicted based upon the monopolar sensing. There did seem to be a directional preference, meaning that the monopolar sensing tended to select contacts that were more back or posterior and medial compared with what we obtained with monopolar review, which was like more anterior and lateral. Now, this actually has just become commercially available and with one of the industries, and they term it now electrode identifier. So this over the last month and a half just became released for the DBS programmers to be able to try and utilize. And what it provides you is along this contact, for example, looking at 21.48 hertz, so kind of on the midpoint of the beta range, you can see that there is the greatest amount of power or greatest amount of amplitude along contact 1C. And you can actually click on this, zoom in, and see exactly what all the distributions are along this frequency. I'll just point out for those who do programming, if listening, you can actually also scroll along and look at other potential signals of interest. So if you had double peaks of beta, you can look at the low beta and the high beta. You can also look at alpha, and you can, of course, look at within the gamma range. What's really powerful about this, I think, and something that is certainly going to be utilized in the future, is it gives the programmer an idea. In this example, it's very simple, that 1C looks like it's the greatest amount of beta, hence this might be the contact to perform. But what happens if you've got 1C that has the high amount of beta, but you also have, for example, 1B that has slightly less, but still a high amount of beta? I think in the near future, you're going to see programmers select 1C and maybe put, for example, 60%, and then maybe 40% on the stimulation on 1B, and directly creating these individualized shapes. And I do think in the future, this might also become automated, meaning it provides the programmer the ideal shape that it predicts based upon the stimulation that is based upon the recordings that are being obtained, and therefore directs the stimulation to be able to be applied within a matter of only several minutes. And then, of course, the programmer can use that as a starting point to then optimize the programming. I'll point out that providing these personalized shapes really can take many weeks or months to actually come up with. And in this situation, we're able to use the recording, i.e., the individual's brain, is telling the programmer what to actually program. I think that's really powerful. So now we're actually able to somewhat listen to the individual's brain. You're also seeing this with another available platform in which we're not recording at this point in time, but now what we're doing is we're looking directly at our target and using imaging guidance to allow us to program the person. So in this example, we want to make sure that we're programming on this back portion of this green blob, and this green blob in this example corresponds with this STN, and it can allow us an automated tell us what might be the contacts and the percentage of those contacts to use to greater fill this area, i.e. the subthalamic nucleus, without having spillage over this region. And you can see that shown here where it provides you with these examples of the percentage of stimulation to provide, as well as what milliamps you might want to perform it at. So this becomes automated as well based upon imaging. A recent study also was conducted looking at this, and they had a total of 64 individuals. And they compared this again, like you saw what we did in our study, to conventional stimulation. And at 1 year, you can see how many of these individuals, what was the concordance, meaning how much did they overlap between what was performed within a matter of minutes by imaging guidance compared with that of the traditional. And you can see that within the levels, there was a high amount of concordance, meaning agreement. With directionality, obviously, there's greater degrees of freedom. Hence, there was some slight differences, but it was about 50% or so of concordance. I also think that in the near future, you're hopefully going to see a combination of using imaging as well as sensing to guide the individual about how to program. So the combination of these two, I think, are going to be utilized. And I think this is going to, A, speed up, increase our efficiency in programming, because it's quite a bit of a burden for individuals that have to keep coming to the clinic, as well as the duration of time that they have to spend within the clinic. But also, we're going to be able to get to better personalized programming within a much shorter period of time. We're also looking at, are there ways to automate the movements, the clinical exam portion, and correlate this, for example, directly to local field potentials, that being the sensing of the individual. This is an example of how we're doing this, and we're looking at all the three different degrees of movement here, meaning anterior, posterior, medial, lateral, and superior and inferior. And you can see the individual, when they start off, they have a high amplitude of the movement, but as they continue, we can see that there is a decrement within the movement. We can also use this to look at the speed of the movement. And I think this is something also that will be utilized in the near future. We're using this in the operating room as a research platform as well. And you can imagine in those centers performing deep brain stimulation where they don't have the expertise, for example, the movement disorder neurologist actually being within the room and they're doing these awake procedures, you can have an automated system with 3 cameras and be able to obtain this type of information where you can see, is my stimulation making a difference, improving, for example, the individual's ability to move? The other incredible hot topic is that of adaptive or closed loop deep brain stimulation. In this model of stimulation, which is now also commercially available, but also being looked at as a research platform, you have a biomarker, a neurophysiological biomarker, and we'll continue to use, for example, low beta as the biomarker. And when you see this amount of stimulation, or amount of beta, the stimulation adapts, meaning it either turns on or turns off, or perhaps it goes up and down within a specific range. I'll point out that there are other centers looking at placing paddles within other surface areas of the cortex and finding that being of great value to also use as a biomarker to then direct how the adaptive or the stimulation will be provided. We do know that, for example, low beta fluctuates during the day and is correlated also with, for example, sleep. And this is work by Dr. Baumgartner, in which he demonstrates that you have higher amounts of beta during the wakeful portions of the day, but then during sleep, this significantly reduces, and this corresponds also with their actual movements. And the question, of course, rises is that right now we provide a continuous amount of stimulation. So the individual, for example, gets 2 milliamps, regardless if they need it or don't need it. So perhaps at night, the individual who doesn't have much of their low beta really doesn't need that degree of stimulation. And of course, there's a lot of work being looked into. Can we improve the sleep architecture by having the stimulation adjust? And perhaps that will result in a greater improvement of the sleep architecture and improving maybe the progression of one's other non-motoric symptoms. So when we combine this at the present time, we now can identify along a contact the optimal contact to potentially utilize using sensing. And then we can also increase stimulation along that, and that's being demonstrated by this orange bar, and see, does our biomarker, this, for example, being in low beta, does that reduce as stimulation progressively increases? As you can imagine, it would be really neat if this was automatically or automated for the individual based upon set parameters that the physician provides. And that's what's actually being utilized at the present time and is performed only available beginning at the end of February to a number of centers, including ourselves. There are 2 commercially available within the United States thresholds that are currently being looked at. One of them is dual threshold, and the other one is single threshold, meaning with dual threshold, the stimulation increases and or decreases based upon the amplitude, the power, the degree of whatever biomarker the physician has selected. Consequently, if, for example, beta goes up and low beta increases, the stimulation goes up. And when low beta goes down, the stimulation goes down. But it doesn't necessarily go completely to 0, and it doesn't go all the way up, for example, to 6 milliamps. Perhaps it modulates between 2 to 3 milliamps in this example. And that differs from single threshold. Single threshold is stimulation is provided at a set milliamps, but then it goes up to another higher amplitude. Let's say, for example, the individual is set at 2 milliamps, and we have a stimulation threshold of 2.5 milliamps. Hence, the individual goes from 2 milliamps up to 2.5 milliamps and back down then to 2 milliamps. And this single threshold is triggered when the neurophysiological biomarker, that, for example, being beta, goes up above a certain threshold and is sustained for a certain duration of time. So once it goes up above, held for a certain duration of time, boom, that will trigger the stimulation in milliamps to go from 2 milliamps to 2.5 milliamps in the example. And yes, the physician can program up to whatever milliamps. You can adjust the duration, and of course, you can adjust the threshold. The utility of using this adapted DBS is really an area of hot interest. We're learning what might be the utility of it on a regular basis. Yes, we know that it potentially is of greater benefit in reducing motor fluctuations, but there are other things that we're also looking at. For example, gait is being looked at, sleep is being investigated. We're looking at side effect profiles that might also be better alleviated. For example, speech, which is a major hot issue that can be potentially worsened with subthalamic nucleus stimulation. Perhaps if the individual is programmed in a single threshold, might this be better? We're also looking at, for example, dyskinesias. Might this be improved? Dyskinesias meaning the abnormal movements that occur in an individual. Might this be reduced by using the individual in adapted DBS? I wanted to point this out is there's other potential biomarkers that might be of great interest, and this is some of the great work by UC San Francisco, and they've identified this fine-tuned gamma being a harmonic of what they think is of the frequency, for example, of 30 hertz, and this is an example at a total of 60 hertz. And they found that this might be also a very good biomarker, neurophysiological biomarker to trigger adapted DBS. And they found this within, for example, the subthalamic nucleus within the DBS electrode itself, but also the paddle electrodes that they have placed over, for example, the motor cortex. So this just to point out that although we talk a lot about, for example, in this a low beta, there's a number of other possible neurophysiological biomarkers that are being hotly looked at. And who knows, in the near future, we might find that there are even better ones that we're currently utilizing even in research right now, but also that are now commercially available. Well, I thank you all for your attention and your time today.